Hey everybody, welcome back to our hypothesis-driven history taking sessions. Today we're going to be talking about the approach to abdominal pain. And I wanted to welcome back Zach.
Hi, everybody.
I wanted to thank him and Bethina and Max for helping me develop the teaching session. So let's get going. Our learning objectives for today are to be able for you to reproduce an anatomic framework to the patient with abdominal pain, to once again fully characterize the patient's complaint, which today is abdominal pain. You use your knowledge of illness scripts in diagnosing the cause of your patient's complaint. And we're going to try to refresh your memory on two things not directly related to abdominal pain, but the CAGE questionnaire, as well as ensure that you know how to obtain obstetric gynecologic history from your patients. So, um, as in the past, I think one of the things that is really important is to really get a good handle on the patient's chief complaint. And so, Zach, what qualities of abdominal pain do the students need to elicit in the HPI?
Great. So the first quality of abdominal pain would be the onset. You can ask, when did this problem start? When's the first time you felt this pain? Next is severity. When you're presenting, you can present it as mild, moderate, or severe. You can have the patient rated on a 1 to 10 scale, and you want to specify that 10 is the most severe pain that you can imagine or that you've ever experienced. Next is location. If it's diffuse, meaning over the entire abdomen, or localized, you can ask the patient to point with their finger where the pain is. The next quality is if it radiates or if it migrates. Radiate means that it like spreads in a line, so the entire line between the 2 points is in pain, versus migrating where it starts in one place and then later on it's in a different place. The pattern of the abdominal pain, so is it episodic? Is it constant? The progression, so has it changed since it first started? The duration of the pain, so how many minutes, days, etc., has the pain been going on for? Any precipitating factors, this might include eating, it might include movement, so similarly, anything that makes it better or worse, and particularly sudden movement, that'll be a clue that maybe they have peritoneal irritation.
Yeah, I think it's really important for students at this point to get a good handle on the abdominal pain and the different qualities of it. Now, when we think about abdominal pain, we often try to distinguish diffuse or generalized abdominal pain from localized abdominal pain. Now, having said that, there can be a bit of overlap between some of these disease entities. So, don't assume that this is going to be a definitive distinction, because some of these diseases may present commonly in a generalized fashion, but also might be in localized fashion. So um, the diseases that often cause generalized abdominal pain may include peritonitis, intestinal obstruction, infectious colitis or gastroenteritis, inflammatory bowel disease, and irritable bowel syndrome. Diabetic ketoacidosis also can present with abdominal pain, as can sickle cell crisis, a rare disease called acute intermittent porphyria, and opiate withdrawal due to adrenal insufficiency, which may occur in these patients. Now, we're not going to talk about all of these diseases, but we're going to highlight some of the ones that you really ought to know. And so Zach is going to take us to the first one.
Sure. So the first illness script is for an intestinal obstruction. This can be in either the small bowel or the large bowel. Some of the qualities of the pain is oftentimes crampy, especially in the small bowel where you have a lot of peristaltic movements. The pain can be either acute or subacute. Similar to it being crampy, it can be intermittent, so it can be off and on depending on the activity of the bowel. When it's more active and moving more, the pain will be more present. And it can progress to developing abdominal distension. Small bowel is more likely to be associated with nausea and vomiting. And because you don't have anything passing through the bowel, there tends to be an inability to pass stool or flatus. Obstructions of the large bowel, the pain can be usually even more diffuse than of the small bowel. Still can be, but less oftenly associated with nausea and vomiting since it's more distal, the obstruction. You can see constipation or overflow diarrhea. And in these patients, you want to be concerned that there might be a malignancy or a volvulus. So some of the risk factors is going to be somebody who has a history of abdominal surgery, because there could be adhesions in the abdominal cavity, malignancies in the large bowel, and even growth in the small bowel, such as in Pugh-Jaeger syndrome, can cause an obstruction. The prevalence increases with age, so you want to have this higher on your radar with an older patient. You can see some of those percentages on the slide. And the timing does depend on the etiology. If it's a slow-growing tumor, it might be a more insidious start versus something like a volvulus that's a little bit more sudden. Next is IBD and IBS. These are similar but distinct diseases. The qualities of IBS, you can look at the Rome 3 criteria. A patient who hits these criteria can be diagnosed with IBS. The first is that the pain improves with defecation. Second is that the onset of the pain is associated with some kind of change in the stool frequency. It can be more or less frequent. And the pain is also associated with a change in stool form. So either more firm or more liquid. In contrast, inflammatory bowel disease, this is either Crohn's or ulcerative colitis. You also do see those functional changes, so meaning constipation or diarrhea. However, unlike IBS, you're going to see blood or mucus in the stool. And this can go on for many years. So you will see a sequelae of chronic malabsorption and possible unintended weight loss. IBD has a known genetic component. It can be associated with HLA-B27, usually diagnosed when patients are a little bit younger. IBS also diagnosed at a younger age, associated with stress and alcohol use. Neither of these are rare diseases. IBD is present in 1 to 2% of the general population, IBS up to 10%. And the timing of these tends to be more chronic. Gastroenteritis and infectious colitis, these are stomach bugs. So you'll see diarrhea that has rapid onset, is non-bloody, and is usually self-limited. Patients come in for this because they're very dehydrated. So you'll see on your physical exam signs of dehydration. They're dehydrated because of their nausea and vomiting, because of their diarrhea, and they can have diffuse abdominal pain. Risk factors include inadequate hygiene, because some of these bugs are transmitted fecal orally. There are environmental risk factors and seasonal risk factors. It can affect all ages. Norovirus is the most common cause, and the timing is going to be acute. This isn't going to be a recurrent infection, so to say. There'll be different infections, but you can see someone have multiple of these over the course of their life.
Yeah, it's really important when you're suspicious of gastroenteritis to make sure you get a good diet history, right? Because there's certain things that people may have eaten at a restaurant or at home that will predispose them to infectious colitis.
Next is diabetic ketoacidosis. This is somebody usually with type 1 diabetes, but can be also type 2 diabetes, whose insulin requirement is greater than their insulin supply. So you'll see very high levels of glucose in their blood and urine that causes a fluid imbalance. So just kind of lump the different symptoms together. The first one I think about is polyuria and polydipsia. Second, because they're not able to absorb glucose into their cells, you'll see a lot of different symptoms because of that, most notably muscle weakness, including in the abdominal wall, which can contribute to the abdominal pain that they're having. And then they're going to have a lot of ketoacids in their blood, so you'll see vomiting, you'll see compensatory hyperventilation, and that's one of the reasons why you'll also see significant cognitive impairment in these patients. So the risk factors, definitely someone who has a known history of type 1 diabetes, although DKA is oftentimes the how a diagnosis of type 1 diabetes is made, so it's not a requirement for a diagnosis. Anything that interrupts their insulin management, and also anything that increases their insulin requirements, such as acute illness, and cocaine use has also been associated with DKA. Again, this is not rare among patients with diabetes. It affects 2 to 3% of people over the course of their lives. And it's not something that you want to miss because it has a high case mortality rate of 4 to 10%. This is going to be an acute illness, and it can be the first episode. They can also have past episodes, though, depending on the exact reason why they went into DKA.
Yeah, I think physicians often forget the prominence of GI symptoms in patients presenting with DKA. So thanks for refreshing our memories on this. Now, we're going to move on to more localized abdominal pain. And I think one of the things that you can do when you have patients who don't have generalized or diffuse abdominal pain is to start thinking of an anatomic approach to abdominal pain. Now, in general, when we think about the abdomen, we think about the four quadrants of the abdomen. And so you have the right upper quadrant, left upper quadrant, right lower, and left lower quadrant. Now, we're going to, in general, people also talk about 9 different regions, but we're going to try to simplify it a little bit because there's also a lot of overlap here depending upon the exact anatomic location of the different structures. So, in general, when I think about abdominal pain that is more localized, I think of 6 general areas that include organs that tend to be localized to these areas. So when we think about the right upper quadrant, we think about the liver, the gallbladder, and part of the intestine, which is at the hepatic flexure. When we think about the left lower quadrant, we can think about the appendix mostly. I'm sorry, the right lower quadrant. And then when we think about the the region below the umbilicus, this is considered the hypogastric or the suprapubic area. There may be several organs that we need to consider. So there's a kidney, the psoas muscle, intestines, of course, the ovaries and uterus, and the bladder. Now, when we move over to the left lower quadrant, we're going to think about the ovaries and the intestine. Once again, think about diseases that affect those. Moving up to the left upper quadrant, we're going to be thinking about the spleen and the splenic flexure. And then right in the center is going to be the epigastric region. And the organs that are in the epigastric region are, of course, the stomach, the diaphragm, the pancreas, and the kidney, and part of the aorta. But you can also get pain that's referred from the heart, the lungs, and the esophagus. So think about those 3 as well as causes of epigastric abdominal pain. And so we're going to kind of move around the quadrants a little bit to see how we can start to remember some of these illness scripts. So we're going to start with the right upper quadrant, and we're going to focus on the more common diseases like hepatitis, biliary diseases, and we've already discussed intestinal obstruction. So I'm going to hand it over to Zach to get us back in the swing of thinking of illness scripts.
Sure. So start with hepatitis. So this is the right upper quadrant section. So you're going to have right upper quadrant and possibly epigastric pain. It can be very severe, especially in acute hepatitis. It's a bit of a broad category of diseases. As you all already know, you can have both acute and chronic forms, depending on what type of hepatitis you have. A lot of these patients, they're going to have fatigue and fever, poor appetite and anorexia, nausea, vomiting, jaundice, dark urine, changes in stool color, ascites, and confusion. The constellation of symptoms, though, is going to depend on their type of hepatitis, but all those symptoms should clue you in that something's going on in the liver because of elevated bilirubin levels in the blood or signs of infection, such as fever. The risk factors, anyone with a history of injection drug use, you want to have the liver on the mind. Alcohol use can cause alcoholic cirrhosis. Unsafe sexual behavior can transmit several types of hepatitis virus. Anyone who's unvaccinated against Hep A and B. Prevalence of hepatitis, it's present in 10 to 35% of hospitalized patients with alcohol dependence. That's going to be an acute form of hepatitis. Acute HB infection is 1 per 100,000 persons in the U.S. You might see someone who is coming to the U.S. from abroad, though they could have higher risk of Hep B. Timing is going to depend on if we're talking about an acute or a chronic form, and when it's acute, it's usually going to be a first episode, such as acute Hep B. Next is biliary disease. There's different kinds of biliary disease. First is biliary colic, where you have a gallstone in your gallbladder, you're going to see intermittent pain that's associated with contraction of the gallbladder. So that's going to be most often after fatty meals, and it's going to be self-resolving because there's no infection. It's just like blocked contraction of the gallbladder. You can see radiating pain to the shoulder and back. Next is acute cholecystitis. This is an infection of the gallbladder. So you're going to see signs of infection, including fever. Because it's infected, it's not just going to self-resolve, it's going to persist beyond that 8 hours. And on physical exam, you can try to elicit Murphy's sign, which is the cessation of inspiration after you place your hand around the site of the gallbladder. And those are all going to clue you in that you have a patient with acute cholecystitis. That infection can extend to the rest of the biliary tract, and you can have cholangitis, where you see severe right upper quadrant pain, fever and chills, jaundice, and you can also have mental status changes. All of these, this whole group of diseases, you're going to see nausea and vomiting. The risk factors for gallstones in general, not my favorite mnemonic, but you can, probably everyone's learned the 4 Fs: female, fat, 40, and fertile. And if you have a family history of gallstones, it clue you in that they have a higher risk. The prevalence of gallstones, it's present in both men and women, but it's slightly more common in women. And the timing can be acute pain. If you have colic because you have gallstones, it's going to be recurrent whenever you eat fatty foods. The infection is usually going to be a first episode.
Great. We're going to move on to the left upper quadrant now, and there we're going to think about diseases of the spleen and the splenic flexure, where there is the intestinal obstruction is also another entity.
So for splenic injury, again, so the pain is going to be left upper quadrant now. If you have diaphragmatic irritation, it can radiate to the left shoulder. If you have peritoneal irritation, it can cause diffuse abdominal pain as well, not just localized to the left upper quadrant. It can also sometimes cause pleuritic pain. So you have different kinds of pain associated with splenic injury, and it can be quite severe. You definitely want to think about what you see in the history to clue you into splenic injuries, because there's going to be something that prompted it. Very common in trauma. So a patient, who has is in a car accident or something, and they have a large spleen, it's going to increase their risk of splenic injury. So there's different diseases that cause splenomegaly, such as infectious mononucleosis, leukemia, and malaria. And there's a number of medications that cause it as well, such as many chemotherapeutics. Some of the risk factors, they include really anything that increases your risk of having splenomegaly. Also can include some inflammatory conditions. Prevalence, very common in blunt abdominal trauma. So anyone who comes in with that, you want to make sure to be ruling out a splenic injury. And the time is going to be acute, and it's going to be a first episode kind of condition.
In the epigastric region, as I mentioned, the things that to think about are conditions that affect the heart and the lungs, which can both refer down to the epigastrium. So we've already discussed this in our prior screencast, so we're going to skip those. But now we're going to talk about diseases that involve the stomach and duodenum and pancreas, and refer back to the previous slide for the biliary diseases, which may also sometimes present in the epigastrium.
Great. So the first group that we're going to talk about is gastritis and peptic ulcer disease. Gastritis, inflammation of the stomach, peptic ulcer disease. You have ulcers in the stomach and duodenum. In gastritis, oftentimes present as an acute condition. You can have chronic gastritis as well. It's going to be associated with nausea, vomiting, you can have weight loss, and you can have fever. But it'll be a variable presentation depending on the severity of the illness. Next, that we want to include in this group is peptic ulcer disease. This is going to be exacerbated when there's stomach acid, so it will be associated with the postprandial state. Whether or not it's during eating or after eating will also depend on if it's in the stomach or duodenum. You can see a lot of these similar symptoms of nausea, vomiting, weight loss, bloating, early satiety. Depending on the severity of the ulcer, you can have hematemesis or melena. And you have a risk of perforation with a peptic ulcer. And if that happens, you're going to have diffuse severe acute abdominal pain. Risk factors include NSAID use, because you're going to have a weakened protective layer of the stomach mucosa. H. pylori infection. So you want to think about patient's travel history. And then certainly any kind of corrosive ingestions, smoking, and stress can all increase your risk of gastritis and peptic ulcer disease. This is this is a pretty common condition. It should always kind of be on your differential for a patient with upper abdominal pain. The reported prevalence of peptic ulcer in the US is almost 10%. And these are going to be subacute or chronic conditions with an acute exacerbation if you have an ulcer that perforates. Pancreatitis, like some of these other conditions, has both acute and chronic forms. What they have in common are going to be severe epigastric pain that's constant and radiates to the back. It can last for days. And if you have a chronic form, patients will come back into the hospital for treatment of their exacerbations of it. Like a lot of these other gastrointestinal diagnoses, you're going to see nausea, vomiting, and you can see abdominal distension as well, depending on the severity. Some of the risk factors of pancreatitis include smoking, alcohol use, hypertriglyceridemia, gallstones, and valproic acid use. You can see we have the prevalences of these. So these are, again, not a rare condition. You'll most likely see a patient with pancreatitis during your medicine clerkship. So it should, again, be on your differential, especially since it can have a variable presentation.
Right. So we're going to move down to the right lower quadrant. And once again, I want to remind you that there can be some overlap in terms of the location of some of these disease entities. So the appendix, think about the appendix in the right lower quadrant, the kidney, the ovaries, and other parts of the female reproductive tract.
So first I'll talk about appendicitis. Here you probably already familiar with the classic illness script for appendicitis. It starts with more diffuse periumbilical pain initially, and that's because it's coming from it's visceral pain. And as the appendicitis progresses, it'll irritate the peritoneum in the right lower quadrant, and so you'll have a progression from initially that diffuse umbilical pain. It'll migrate. You'll have sharp pain at McBurney's point later on, which is 2/3 on the way from the umbilicus to the anterior superior iliac spine. Appendicitis patients will have anorexia, so loss of their appetite. Almost all the time they'll have nausea and frequently vomiting as well. If the appendix perforates, which is what you're most concerned about in a patient with appendicitis, you'll see diffuse peritoneal signs, including rebound tenderness, guarding, and a diffusely tender abdomen. Most common appendicitis happens in people aged 10 to 30. And you want to seek immediate treatment because anyone who presents greater than 24 hours after onset has a significantly increased risk of perforation. It's a relatively common condition with a 1 in 10 lifetime prevalence, and this is always going to be an acute first episode diagnosis. No one comes in with recurrent appendicitis. Next is a renal colic. These are kidney stones. The classic illness script is going to be unilateral flank pain that radiates down the abdomen into the groin. I tend to think about the illness script as kind of similar sometimes for testicular and ovarian torsion, because it'll also be associated with nausea and vomiting. It'll be colicky and intermittent, even though they're very different diagnoses. Some of the associated symptoms will be hematuria, dysuria, and you have urgency and frequency. These patients are very, very, very uncomfortable. The risk factors, so there's different kinds of kidney stones and different things that predispose it to you. So it's a lot of different risk factors. Some of them include having a low fluid intake or being dehydrated, because then it'll be more likely that a stone will form. Different genetic factors can play a role. So if you have a family history, and obviously if you have a personal history, you have an increased risk of having another kidney stone. Hypercalciuria and anatomic abnormalities, all these things can increase your risk of having a renal colic being the cause of your pain. There's also not an uncommon diagnosis. There's wide variations in the reported prevalence, ranging from 1% to 20% during their lifetime. There's going to be an acute quality, and patients may come in with their first episode. It may also oftentimes have recurrent episodes depending on their predisposition to forming these things. Next is ovarian torsion. I mentioned this during the renal colic slide. The pain is going to have similar qualities, but unilateral, variable intensity, but oftentimes very severe. It'll be sudden onset, it'll be constant, or it can be intermittent, and it may be positional. Oftentimes it'll radiate from the flank down to the groin, and it'll also oftentimes be associated with nausea and vomiting. Increased risk of ovarian torsion is because your ovaries are a larger size, and so they're more likely to twist upon themselves. Having large cystic kidneys will increase your risk of having torsion, so you might want to think about assessing the risk of having cystic kidneys by getting a menstrual history. Some of the other risk factors include any kind of mass, being pregnant, and then of course having a history of it, and other conditions of the ovaries and fallopian tubes will increase your risk. Of surgically treated adnexal masses, 15% of them are due to torsion, and this is going to be an acute illness. Oftentimes will present as a first episode, but it can be transient or recurrent. They can report having frequent or intermittent episodes of this kind of pain that goes away on its own, and that's because the ovary is twisting on itself and then untwisting and then twisting and untwisting, so it can cause two different kinds of patterns. Next is ovarian cyst rupture or hemorrhage. So this is going to be a patient who complains of unilateral sudden onset pain that should be self-limited, so you can reassure these patients, because what's happening is it can be a physiologic cyst rupture, so that means 14 days before their next menstrual period, their corpus luteum is forming and they have a physiologic cyst rupture that causes pain. That's called Mittelschmerz. So you want to get a thorough menstrual history for these patients and figure out if that could be what's going on. Anything that increases their number of ovarian cysts, such as progesterone-only contraceptive pills, or if they're undergoing fertility treatments, will also increase their risk of having ovarian cysts, and so they're more likely to have a painful ovarian cyst rupture. This is a pretty common diagnosis, one of the most common for patients with this kind of pain who fall into women of reproductive age, and this is going to be, again, acute pain. It can be their first episode. They can also have past episodes of this. Next is we're going to talk about disease of the fallopian tube that can extend to the rest of the pelvis. So there's going to be pelvic inflammatory disease, which is infections of the fallopian tubes and surrounding structures. We'll talk about ruptured ectopic pregnancies, because both of these, when we think about this anatomic framework, both of these are most primarily in the same anatomic structure, the fallopian tubes. These patients are going to have generalized symptoms of fatigue. In pelvic inflammatory disease, that'll be more chronic, and ruptured ectopic pregnancy will be very acute. You're going to see changes in the reproductive tract. So you'll see abnormal discharge and heavy periods. That's why always getting a thorough OBGYN history is going to be important for patients with lower abdominal pain. A patient with a ruptured ectopic pregnancy, they're going to have a recent history of amenorrhea because they've been pregnant, so their menstrual periods have been suppressed. And patients with pelvic inflammatory disease, they often go on to develop infertility, and also people with ectopic pregnancies because they're going to have fallopian tube scarring. Both of these conditions can cause symptoms outside the reproductive tract, peritoneal symptoms because of irritation, and in pelvic inflammatory disease, you can develop Fitzhugh-Curtis syndrome, where you have a lot of involvement of many structures in your abdominal cavity extending up to your liver. Risk factors are going to be a history of STI and pelvic inflammatory disease, so getting a thorough sexual history is going to be important. Neither of these conditions are rare. Ectopic pregnancies occur in 1 to 2% of all pregnancies, and they're more often seen in patients with ART, such as IVF and other medications that'll increase your, that'll stimulate ovulation. Pelvic inflammatory disease has a reported lifetime incidence of 1 to 2%. The timing is going to depend on exactly which of these we're talking about. PID is going to be subacute or chronic, and a ruptured ectopic pregnancy will be an acute, usually first episode diagnosis.
Great. Now we're going to move over to the left lower quadrant, where similarly the ovarian diseases and diseases of the left reproductive tract are going to be prominent, but one disease entity to take note of is diverticulitis.
Great. So diverticulitis, disease of the large bowel, can happen on the right or the left side, but is more frequently and classically seen in the left lower quadrant. And depending on which side it's in, it'll be more localized, opposed to diffuse. These patients will have fever, nausea, vomiting, diarrhea, dysuria, anorexia, and as you'll see, a lot of the associated symptoms are overlap between a lot of different diseases of the gastrointestinal tract, which is partly why I think this anatomical framework is really useful. Think about where the pain is and which structures are there. The risk factors will be increasing age, constipation, related to that, low dietary fiber intake, and then obesity and use have both been associated with diverticulitis. Also not an uncommon diagnosis. And the timing is going to be, it can be acute, it can be, first it can be recurrent, depending on the patient.
The last part of our the abdomen we're going to talk about is the hypogastric regions. That's the area below the umbilicus. So we think about the small and large intestines. We think about the abdominal aorta and the bladder.
So first is bowel ischemia. This can be mesenteric ischemia or ischemic colitis, where you have impaired blood flow to your bowel. And whether it's the large or the small bowel, and like many of these other conditions, you're going to see GI symptoms, including nausea and vomiting. In ischemic colitis, you're going to see oftentimes bloody diarrhea. And especially in mesenteric ischemia, you'll see what's called pain out of proportion to exam. So the patient's complaining of very severe pain. When you go to elicit it, when you examine the patient and palpate, it's not quite so tender, but they have severe pain. And you can see this progress to having significant abdominal distension, partly secondary to ileus. These patients will usually present with systemic symptoms as well, fever, chills, tachycardia, tachypnea, and they can have mental status changes. And especially because older age is a risk factor, that's partly why you'll see those systemic symptoms and so a little more susceptible to generalized illness. Patients who have undergone surgery have an increased risk of bowel ischemia, and any kind of vasculopathy, including atherosclerosis or being in a hypercoagulable state, anything that can interrupt your blood flow to your bowels. Prevalence, if you look at all patients, you see a prevalence about 1%. So it's not uncommon, but it really increases when you look at patients over the age of 70. So older age is a really significant risk factor for bowel ischemia. And the timing is going to depend on the etiology. You could have an atherosclerotic lesion that fully occludes, and that might be a more insidious onset of, let's say, ischemic colitis. On the other hand, you could have an embolus thrown to your superior mesenteric artery. It's going to cause a very sudden, acute, terrible pain out of nowhere due to interruption of the mesenteric blood flow. Next is a ruptured abdominal aortic aneurysm, very life-threatening, which is why some patients can be screened for abdominal aortic aneurysms. They're usually asymptomatic, which is why they need to be screened for. So a patient might know that they have one, they might not know that they have one. The triad of symptoms with a ruptured AAA is going to be severe acute pain associated with a pulsatile abdominal mass and sudden hypotension. You can review your anatomy slides to think about what the branches are off of the abdominal aorta, because you can see symptoms associated with which of those branches are interrupted. So if you have involvement of the renal arteries, you're going to have renal impairment. If you have involvement of the mesenteric arteries, you're going to have intestinal impairment. And if you have inclusion of the artery of Edenkiewicz, you're going to have lower spinal involvement. So it depends on where the aneurysm is, can affect what associated symptoms you have. Some of the risk factors are older age, male, and smoking. And so patients who fit those risk factors are usually the ones who are being screened for. In those screening studies, those patients at increased risk, they're pretty common, 4 to 8%, but they're usually small aneurysms. It's the larger aneurysms that are at higher risk of rupture. And the true incidence of rupture is difficult to estimate. Most patients, I think it's about 50% or so of patients don't make it to the hospital. These are can be very fatal. The measured incidence is about 5 per 100,000, but it's likely much higher than that. And the timing is going to be an acute and it's going to be a first episode diagnosis. Next is cystitis. So this is infection of your bladder. You can have uncomplicated cystitis, meaning that it's has not reached your kidneys. These patients will have suprapubic pain, dysuria, frequency, urgency. Less commonly, but still possible, is gross hematuria. It can progress to pyelonephritis, infection of the kidneys, where it's kind of plus minus having those cystitis symptoms, but you're going to have fever and chills, flank pain, nausea, and vomiting. It's a pretty significant illness. These patients are going to be sick, and many of them are hospitalized for treatment. Risk factors for cystitis include sexual intercourse or having new partners. Spermicide use has been associated with this, believed to be because it disrupts the vaginal flora. There are some anatomic and risk factors, so you can have to have a family history that increases your risk. Of course, if you have a previous UTI, you're going to be increased risk of developing another UTI, and patients with diabetes are at increased risk. The prevalence decreases with age, but it ranges among adult women from 10 to 15%. These are going to be acute kinds of pain. It can be recurrent, though. Patients can develop multiple episodes of cystitis throughout their life.
Yeah, so going off the abdominal pain illness scripts now, one of the things we wanted to emphasize during the sessions also is the importance of doing a good social history. And one of the things that you ought to learn is something called the CAGE questionnaire. You want to take it from there?
Yeah, of course. So the CAGE questionnaire is a series of 4 questions that have been shown to be very useful in screening for alcohol use disorder. And it's called CAGE because it's an acronym, as you can see. The first is C, stands for cut down drinking. So you can ask, have you ever felt that you should cut down on your drinking? Their own perception. Next is A for annoyed. Have people annoyed you by criticizing your drinking? Next is G for guilty. Have you ever felt guilty about drinking? And lastly is eye opener. Have you ever felt you needed a drink first thing in the morning? Which colloquially is called an eye opener, to steady your nerves or to overcome a hangover. And a patient who answers yes to at least 2 of these, it's considered a positive CAGE test.
Yeah, and finally, we're going to expect you to do an OBGYN history on the standardized patient you'll be seeing. So, what are the elements of an OBGYN history?
So the first element of an OBGYN history is going to be the menstrual history. This includes the age at menarche, so when they started having periods, the date of their last menstrual period, and their menstrual pattern. So how long each cycle is, the duration amount of menstrual flow, if there's pain, and if they ever have intermenstrual bleeding. You also want to understand if this patient is perimenopausal or postmenopausal. And if so, you want to understand their bleeding pattern, if they have any vasomotor symptoms of menopause, and if they're undergoing or have undergone hormone replacement therapy. Next is a contraceptive history. Are they currently using contraception? Or are they satisfied with that method? Because there's lots of choices available. You want to know what methods they've tried in the past, including any complications and reasons why they stopped those methods. Next is a thorough obstetric history. So you need to have patients list all of their pregnancies, including all of them, not just ones that went to term, and the outcome. You want to describe any maternal, fetal, or neonatal complications, of course. And in notes and presentations, you can use the G1, P1, or GRAVID nomenclature to communicate succinctly this patient's overall obstetric history. Pap smears screen for cervical cancer. You want to know the most recent date of their pap smear if they have any past abnormal smears. And next is the infection history. Do they have any history of STIs, any history of vaginitis, any known history of pelvic inflammatory disease? Next in a thorough OBGYN history is their fertility and infertility. You want to know if they have a desire for future fertility. Do they have any difficulty conceiving in the past? And if so, did they undergo any prior evaluations or treatments? And lastly is the sexual history, which I know you all are familiar with. The type of sex that they have, their partners, do they have any pain or discomfort during sex? How's their libido? Do they have any concerns about it? And that should be a pretty good start to taking a good OBGYN history.
Well, Zach, I know that that was a lot of information, and it's because it's a lot in the abdomen. So, abdominal pain is a really common complaint that you will see both in the inpatient and the outpatient settings, both in the medicine or the surgical clerkships. So, I think it's a really important one to master. We'll continue to um, I think the students continue to emphasize the importance of coming to a leading diagnosis, but also entertaining alternative diagnoses during your history taking. That's what we call hypothesis driven history taking. So thank you for your attention. And once again, thank you very much, Zach.
Thank you, everybody.